happens to the lungs when smoking? If your guess is they turn colorful, you are wrong. When an individual smokes a cigarette, harmful chemicals are inhaled. These chemicals can cause swelling of the bronchial tubes in the lungs, thus resulting in the excess production of mucus, leading to chronic diseases like chronic bronchitis and emphysema. It also damages the cilia that help in pushing out the excess mucus. As a result, the bronchial tubes get clogged. This leads to persistent coughing as an attempt of clearing out the mucus out of our body. Smoking cigarettes increases the likelihood of respiratory infections as well. In this project presentation today, we'll be discussing the health risks of smoking. We'll start off with the roles of smoking in increasing the susceptibility to respiratory tract infections. Next comes the roles of smoking in the development of obstructive and restrictive airway diseases along with lung cancers. Last but not least, we'll touch on the pharmacological and non-pharmacological treatments for chronic smokers with respiratory disorders. Heads up everyone, this is going to be a long yet an interesting one.
Good day everyone. Did you know a cigarette smoker is at a higher risk of attaining many acute respiratory infections? Smoking can increase the incidence, duration, and severity of respiratory infections caused by numerous types of viruses and bacteria. It is therefore likely that smoking has a causal role in acquiring acute respiratory infections. For an instance, is an invasive pneumococcal disease. Cigarette smokers suffer from colds, have several-fold higher and more severe cases of influenza, and are at increased risk of bacterial pneumonia compared to non-smokers.
The question now is, how does smoking increase the susceptibility to respiratory infections in smokers? The mechanisms are multifactorial and include alterations in structural and immune defenses. The structural changes caused by smoking include inflammation, fibrosis, where there is a formation of disruptive scar tissue, changes in pathogen adherence, and disruption of the respiratory epithelium. Smoking disrupts the innate immunity responses and adaptive immune responses, changes the microbiota in the respiratory tract, and has pathogen-related effects. Now you may be wondering, what are pathogen-related effects? They are proposed to increase infection rates and impact on outcomes include an increase in the virulence of bacteria with smoke exposure, increase in the ability of pathogens to adhere to respiratory tract membranes, and increase in resistance to antibiotics.
What does smoking do to the immune system? It disrupts the normal functioning of the immune system that fights the infection in the respiratory tract. Smoking may cause an increase in the number of white blood cells, which are immune cells in the blood and lung fluids, consistent with harmful effect of inflammation. Not only that, smoking also causes impairment of the normal functioning leukocyte, reducing the ability to clear infections.
The innate defense system of the lung includes the apparatus for producing and clearing mucus, the epithelial cell barrier, and infiltrating inflammatory immune cells. The pulmonary epithelium plays a critical role in the host defense by recognizing insults and initiating innate responses. The inhalation of tobacco smoke interferes with these defenses, resulting in both increased production of mucus and decreased effectiveness of the clearance process in the airways lumen. Impairment of these defenses increase the potential for infection. Tobacco smoke also disrupts the tight junctions that form the epithelial barrier and initiates the infiltration of the damaged tissue by a variety of inflammatory immune cells, including polymorphonuclear and mononuclear phagocytes, natural killer cells, CD4 plus and CD8 plus T cells, and B lymphocytes. The lymphocytes become organized into lymphoid follicles with germinal centers to mount an effective adaptive immune response.
In this part of the video, we'll go through the roles of smoking in the development of chronic obstructive airway diseases, COPD, restrictive airway diseases, as well as lung cancers. In COPD, the commonly involved diseases are emphysema and chronic bronchitis. As for restrictive airway diseases, the commonly associated disease with smoking is desquamative interstitial pneumonia. The lung cancers that are involved as a consequence of smoking are squamous cell carcinoma and small cell lung carcinoma.
What is COPD? Chronic obstructive pulmonary disease, or commonly abbreviated as COPD, is a chronic inflammatory lung disease that causes obstruction in the airflow of the lungs. The symptoms presented are breathing difficulty, cough, sputum production, and wheezing, which are typically caused by a long-term exposure to irritating gases or particulate matter, most often from cigarette smoke. COPD patients are at increased risk of developing heart disease, lung cancer, and a variety of other conditions. The most common COPD are emphysema and chronic bronchitis, where 80% of the cases are due to smoking.
What is emphysema? Emphysema is a condition where there is a permanent enlargement of air spaces distal to terminal bronchioles and a destruction of the walls without significant fibrosis. There are 4 types of emphysema, which are centri acina emphysema, most commonly seen in cigarette smokers and often associated with chronic bronchitis. Second, we have panacina emphysema, commonly at the lower zone of the lung and is associated with alpha-1 antitrypsin deficiency. The third one is distal acina emphysema, and the last one is the irregular emphysema.
How does cigarette smoking lead to the development of emphysema? The inhaled cigarette smoke and other noxious particles cause lung damage and inflammation, which results in parenchymal destruction, leading to emphysema and airway diseases, which are bronchiolitis and chronic bronchitis. Cigarette smoke causes the inflammatory response in the lower respiratory tract, characterized by the accumulation of pigment-laden alveolar macrophages, together with the recruitment of smaller numbers of neutrophils. These activated inflammatory cells release a variety of mediators, including proteases, oxidants, and toxic peptides. The mediators can damage lung structures and are believed to be a major cause of the tissue destruction, by which emphysema is defined. The factors that lead to the development of emphysema include the inflammatory cells and mediators, protease-antiprotease imbalance, oxidative stress, and airway infection.
Patients with emphysema will present with dyspnea, which begin insidiously but steadily progressive, cough, wheezing, barrel chest, prolonged aspiration, sitting forward in a hunch-over position, and pink puffers due to prominent dyspnea, and adequate oxygenation of hemoglobin. The morphological features of emphysema include the enlargement of the air spaces with destruction of alveolar septa without fibrosis, pale and voluminous lungs, and loss of elastic tissue.
The other common COPD involved, as mentioned before, is chronic bronchitis, a condition where there is a presence of persistent cough for at least 3 consecutive months in at least 2 consecutive years. This condition is common in smokers and urban dwellers in smoke-ridden cities. It affects 20 to 25% men in 40 to 65 years old age groups. The development of chronic bronchitis in smokers begins. The airway lining cells are damaged, leading to chronic inflammation. It also interferes with the ciliary action of the respiratory epithelium, which then prevents the clearance of mucus, leading to the hypersecretion of mucus, a distinctive feature of chronic bronchitis. These irritants induce hypertrophy of mucous glands as well as increase in mucin-secreting goblet cells. It causes inflammation marked by the accumulation of inflammatory exudate. The accumulation of exudate in the airway of the lungs increases the risk of infections. If there is a long-standing inflammation and accompanying fibrosis involving small airways, it can lead to chronic airway obstruction.
Patients with chronic bronchitis typically present with persistent cough with production of sparse sputum, mild cyanosis, and sometimes clubbing fingers. Patients have no other history of respiratory functional impairment, and eventually dyspnea on exertion develops. The morphological changes seen are enlargement of mucus-secreting glands with thickened mucous gland layer, presence of various inflammatory cells. Bronchial epithelium shows metaplasia and dysplasia. The Reed index is higher than 0.4, which is the normal Reed index. Reed index is defined as the ratio of the thickness of the mucous gland layer to the thickness of the bronchial wall between the epithelium and the cartilage.
Moving on to the restrictive lung diseases, desquamative interstitial pneumonia (DIP) and respiratory bronchiolitis are two related examples of smoking-associated interstitial lung disease. The most striking histological feature of DIP is the accumulation of large numbers of macrophages containing dusty brown pigment, also referred to as smoker's macrophages in the hair spaces. The alveolar septa are thickened by a sparse inflammatory infiltrate. Interstitial fibrosis when present is mild. Pulmonary function tests usually show a mild restrictive abnormality. Patients with DIP have a good prognosis and an excellent response to steroids and smoking cessation. However, some patients progress despite therapy. Respiratory bronchiolitis is a common lesion found in smokers that is characterized by the presence of pigmented intraluminal macrophages akin to those in DIP, but in a bronchiolocentric distribution.
Cigarette smoking plays an important role in the development of lung cancers. Approximately 90% of lung cancers occur in smokers. Components of cigarette smoke are potent carcinogens and involved in the causation of lung carcinomas. Exposure to environmental tobacco smoke is also associated with detrimental effects. Passive smoker inhalation in non-smokers can be estimated by measuring the blood levels of cotinine, a metabolite of nicotine. The relative risk of lung cancer in non-smoker exposed to environmental smoke is about 1.3 times more than in non-smoker who are not exposed to smoke. Maternal smoking increases the risk of abortion, premature birth, and intrauterine growth retardation. The four major histologic types of lung cancer are adenocarcinoma, squamous cell carcinoma, small cell carcinoma, and large cell carcinoma. In some patterns, there is a combination of histologic patterns. Of these, squamous cell carcinoma and small cell carcinoma show the strongest association with smoking.
Lung carcinomas are divided into big groups: small cell lung carcinoma, SCLC, and non-small cell lung carcinoma, NSCLC. SCLC have metastasized by the time of diagnosis and are not curable by surgery and are the best treated by chemotherapies with or without radiotherapies. NSCLC are more likely to be resectable and are usually respond poorly to chemotherapies.
Smoking-related lung carcinomas arise by a stepwise accumulation of a multitude of genetic abnormalities that result in transformation of benign progenitor cells in the lung into neoplastic cells. The development of lung carcinomas in smokers starts with the inactivation of putative tumor suppressor genes located on the short arm of chromosome 3 monosomy 3p as a very early event, whereas TP53 mutations or activation of the KRAS oncogenes occur relatively late. Large areas of the respiratory mucosa are mutagenized after exposure to carcinogens. Those cells that accumulate additional mutations develop into cancer. After exposure to carcinogens, the basal cell of the lungs undergoes hyperplasia and squamous metaplasia and progresses into squamous dysplasia and carcinoma in situ, before culminating in invasive cancer. Among the major histologic subtypes of lung cancer, squamous and small cell carcinoma show the strongest association with tobacco exposure.
The mucosal changes in lung carcinomas begin as small mucosal lesions that typically are firm and grey-white in color. They may arise as intraluminal masses invading the bronchial mucosa or forming large buccally masses that push into adjacent lung parenchyma. Some large masses undergo cavitation secondary to central necrosis or develop focal area of hemorrhage. Finally, this tumor may extend to the pleura, invade the pleural cavity and chest wall, and spread to adjacent intrathoracic structure. More distant spread can occur by way of the lymphatic or hematogenous spread.
In squamous cell carcinoma, it is more commonly seen in men than women and closely related with a smoking history. The carcinoma tends to arise centrally in major bronchi and spread to local hilar nodes, but disseminate outside the thorax. Large lesions in the lungs may undergo central necrosis, which give rise to cavitation. The bronchial epithelium also undergoes squamous metaplasia or dysplasia and transforms to carcinoma in situ, which may last for several years. By this time, atypical cells may be identified in cytologic smears of sputum or in bronchial lavage fluids or brushing, but this lesion is asymptomatic and undetectable on a radiograph. When the small neoplasm reaches a symptomatic stage, this well-defined tumor starts to obstruct the lumen of major bronchus and producing distal atelectasis and infection. This lesion will invade the surrounding pulmonary substances. The histological changes are well-differentiated squamous cell neoplasms, showing keratin pearls and intercellular breaches to poorly differentiated neoplasms, exhibiting only minimal residual squamous cell features. The last lung carcinoma to be discussed is small cell lung carcinoma. It appears a pale gray, centrally located mass with extension into the lung parenchyma with early involvement of the hilar and mediastinal nodes. Tumor cells are round to fusiform shape with sense cytoplasm and finely granular chromatin. The size of the neoplastic cells is small, but it's twice the size of resting lymphocytes. In small cell lung carcinoma, necrosis may be present and may be extensive. The tumor cells are fragile and often show fragmentation and crush artifact in small biopsy specimens. In cytologic specimens, there is nuclear molding which results from the close opposition of tumor cells that have sense cytoplasm. The tumor cells express a variety of neuroendocrine markers in addition to secreting a host of polypeptide hormones that may result in paraneoplastic syndromes.
Phew, that was a long one for the respiratory diseases related to smoking. Now that we've discussed it thoroughly, let's get into the strategies for smoking cessation that includes the pharmacological and non-pharmacological ways, as well as the drugs and treatments used in the cessation of smoking.
Quitting smoking is not as easy as we thought because chronic smokers are addicted to the chemicals contained in the cigarettes. There are stages of quitting smoking where in the first 20 minutes of quitting, the heart rate and blood pressure drop back to normal levels. In the next 12 hours, the level of carbon monoxide in the blood drop back to normal too. If this persists for 2 weeks, the blood circulation and lung function improve and restore back. 6 weeks of quitting skyrockets the energy levels. Continuing for 6 months of quitting helps in disappearing the smoker cough and shortness of breath, leading to a great improvement in lung capacity. After a year, the risk of heart disease reduced to half as high as a non-smoker.
Patients presented to a healthcare settings are usually asked to do a screening for tobacco use. If a patient is a current user of tobacco, physicians would help a smoker to quit it by following 5 A's. Firstly, ask and advise patients to quit smoking every visit. Assess their willingness to quit during every next visit and continue assisting them within 2 weeks with pharmacotherapy or counseling. Lastly, Arrange follow-up contacts in the first week after quitting to monitor the progress. Albeit this, there are some smokers that may be reluctant or unwilling to quit smoking. Hence, 5 R's are followed. Start off by explaining the relevance, which is the importance of quitting thoroughly. Next is breeze, telling them the consequences of their ongoing habit of smoking and how it will deteriorate their health. Rewards such as benefits of tobacco cessation should be explained as well. Roadblocks, which stands for the identification of their impediments and the hindrance to quit. Lastly and most importantly is to do repetition, where all the 5 R's are repeated every visit until the patient is willing to stop smoking. For ex-users, relapse prevention is implemented.
Smokers who intend to quit are also offered counseling programs. There are different ways of conducting such a program, like a brief intervention where the patient joins the program for a certain period of time, individual counseling, and group counseling. They also offer online smoking cessation interventions, and it is proven that internet and mobile telephone program can be effective for up to 12 months for assisting smoker to quit. Aside from non-pharmacological therapy, there is pharmacological therapy which can be used to assist smokers to quit smoking. The pharmacological therapy is divided into nicotine-based and non-nicotine-based, where the examples of the former are nicotine replacement therapies like gum, patch, lozenges, and inhaler. The non-nicotine-based drugs are varenicline, sustained-release bupropion, and nortriptyline. The benefits of nicotine replacement therapy is to reduce withdrawal symptoms associated with stopping smoking by replacing the nicotine from cigarettes.
In nicotine replacement therapies, it provides some of the nicotine that a smoker would have otherwise received from tobacco, and in doing so reduces the person's urge to smoke. All NRT products roughly double a smoker's chance of stopping compared with a placebo. Patients should use NRT for at least 8 to 12 weeks, and if he is not ready to stop smoking straight away, NRT can be used to help reduce his smoking before he stops. There are 4 different NRT products available in Malaysia, including the patch, gum, lozenges, and inhalator. The first step of using nicotine patches is by marking the quit date and putting the patch in the morning, keeping it on till the next morning. Step 2 is use a new patch every day until the patches are gone. The patches should be put on a clean, dry part of the upper body that is not hairy. Press the patches firmly to the skin for 10 to 20 seconds for better adhesion. Always remember to change the patch placement every day and avoid putting on the same spot for at least 1 week.
The non-nicotine based drugs include varenicline, reduces a person's urge to smoke as well as the reward they get from smoking, and at least doubles a person's chance of stopping smoking. Varenicline binds with high affinity and selectivity at alpha-4 beta-2 neuronal nicotinic acetylcholine receptor. The efficacy of varenicline in smoking cessation is believed to be the result of varenicline activity at a subtype of nicotinic receptor where its binding produces agonist activity while simultaneously preventing nicotine binding to alpha-4 beta-2 receptors. Before prescribing or recommending varenicline, check the contraindication and cautions that apply. Pregnant or breastfeeding women and people under the age of 18 cannot use varenicline. Patients should use it for 12 weeks. Common adverse effect includes nausea, abnormal dreams, and sleep disturbance. Most serious adverse events such as cardiovascular events, depression, suicidal ideation, and suicide has been reported, although these are uncommon. If someone using varenicline experiences changes in mood or behavior, advise them to stop taking varenicline and contact a healthcare provider immediately. The next non-nicotine based drug is bupropion, which is an atypical antidepressant that reduces the severity of tobacco withdrawal and approximately doubles a person's chance of stopping smoking. Bupropion is a norepinephrine dopamine reuptake inhibitor that exerts its pharmacological effects by weakly inhibiting the enzyme involved in the uptake of the neurotransmitters norepinephrine and dopamine by the synaptic cleft, therefore prolonging the duration of the action within the neuronal synapse and the downstream effects of these neurotransmitters. Most specifically, bupropion binds to the norepinephrine transporter and the dopamine transporter. People should start bupropion at least 1 week before they quit date and use it for at least 7 weeks. The contraindications are pregnant or breastfeeding women and people under the age of 18 cannot use bupropion. Common adverse effects include dry mouth, insomnia, and headache. Seizure has been rarely reported and depression has been reported in some people.
The other drug used is nortriptyline. It is a tricyclic antidepressant that inhibits the reuptake of noradrenaline and serotonin. It acts through its noradrenergic mechanism, reducing the severity of withdrawal symptoms. Its smoking cessation properties include its anxiolytic effect and anticholinergic side effects such as dry mouth, which may make cigarette less desirable. It is contraindicated in those who have experienced a recent myocardial infarction or arrhythmia. Severe liver disease is another contraindication. In addition, there are a number of precautions to note, such as use in people with cardiac disease, a history of epilepsy or psychosis, and women who are pregnant or breastfeeding.
Clonidine can also be used. It is an alpha-2 adrenoceptor agonist that reduces sympathetic activity by decreasing noradrenaline release. It is generally used as an antihypertensive and for prevention of recurrent migraine, but has also been used for smoking cessation. Clonidine reduces craving for smoking by acting on the sympathetic nervous system to reduce the symptoms of tobacco withdrawal. The adverse effects associated with this medication, such as postural hypotension, dizziness, and dry mouth, makes its use less desirable. In addition, clonidine causes sedation, although this might be some of benefit to those who experience more intense symptoms of tobacco withdrawal. Depression, sleep disturbance, and constipation also occur, yet these are so classic symptoms of nicotine withdrawal. Patients with a history of depression or occlusive peripheral vascular disease should avoid using clonidine. If clonidine is to be used for smoking cessation, then treatment should be started 2 to 3 days before quitting, allowing time to reach steady state concentration. Clonidine can be taken orally or through a transdermal patch.
The last non-nicotine based drug that can be used is silver acetate. It has been used as a form of aversion therapy for smoking cessation. Smokers are instructed to use the product, which comes in the form of chewing gum, spray, or lozenges on a regular basis. When used in combination with smoking, an unpleasant metallic taste is produced, thus making smoking less desirable. In addition, argyria, which is a skin discoloration due to silver deposition on skin, is an adverse effect that need to be avoided. It is recommended that the user should not exceed a total dose of 756 mg.
Both nicotine replacement therapies and non-nicotine based drugs have its pros and cons. Nicotine replacement therapy lowers the nicotine blood levels and has no exposure to potentially toxic chemicals in tobacco cigarettes, with no evidence of adverse perinatal effects. The cons include a non-significant trend towards a benefit and has low adherence to therapy. Varenicline increases smoking cessation rates as well as reduces cravings and total nicotine withdrawal symptoms. It has a higher quitting rate than nicotine patches. Bupropion has both agonistic and antagonistic properties that are believed to account for reduction of craving and withdrawal, as well as blocking the rewarding effects of tobacco cigarette smoking. The con for both varenicline and bupropion is that the metabolites can cross the placenta to the fetal circulation. There are possible malformations when the drugs are used in the first trimester of pregnancy.
And that's a wrap for the discussion today. We hope you'll have a clear insight of the health risks of smoking and can help to relay this knowledge to those who may be concerned. Stay tuned for a quiz that will be conducted right after this video presentation ends. Goodbye!